Hello, everyone. For those of you who are just tuning in, I'm Elisa Manel. I'm the director of the Center for Retirement Research at Boston College. And it is my great pleasure to introduce Ann Case, our keynote speaker. Ann has a long list of accomplishments, but I mainly want to talk about her new co-authored book, Deaths of Despair and the Future of Capitalism. I thought I should at least skim this book in preparation for Ann's appearance today. But let me tell you, I didn't skim it. I read it cover to cover, and I read it pretty fast. But my husband, who is not an economist, he's the farthest from an economist as you can be, also took it and read it in 24 hours. And so now it's sort of required reading in Boston. It is not only an insightful look at a critically important topic, but it's beautifully written, as you know, not all academic papers are, and it's a page turner. How did this all happen? It's not surprising that the book's become a bestseller. Many of you are familiar with the central issue at the heart of the book. Ann and her co-author and husband, Angus Deaton, first published a paper on this topic a few years ago. The paper highlighted a startling new trend that death rates among middle-aged whites without 4 years of college had begun to rise. While some of the causes had emerged on our radar screen, particularly the opioid epidemic, no one had really looked at all the factors that were affecting the mortality of this group. This initial paper caused an immediate stir among demographers and health researchers, and its message also reached the media and the culture at large. It has spawned new research and influenced a broad range of policy debates. Since that original work, Ann and Angus have expanded their exploration to look at the root causes of this disquieting trend, and thankfully, to suggest some potential solutions. The solutions are not designed to make the world perfect, but to make things better. I really like the tone of the last chapter. I won't say anything more about the book itself since we have Ann here to tell us about it. But before I turn it over to her, I wanted to mention just a few of her many accomplishments. Ann is the Alexander Stewart 1886 Professor of Economics and Public Affairs at Princeton. Her many awards include the Kenneth J. Arrow Prize in Health Economics and the Cozzarelli Prize from the National Academy of Sciences. She is also a research associate at the NBR, a member of the National Academy of Sciences, the National Academy of Medicine, the American Academy of Arts and Sciences, and the American Philosophical Society. And now, without further ado, I'm pleased to give you Ann Case.
Thank you so much, Alicia, and thank you so much for the invitation. It's great to be with you today. And I am going to talk about my new book with Angus, which, here we are, which came out in March of this year. It's available from booksellers. I'm trying to get, my screen seems to have frozen on me. There we go. Deaths of Despair and the Future of Capitalism. And it's a grim topic. It's the other epidemic, but it's an epidemic that's been occurring under the radar for a very long time. So the book is based on a lot of work that Angus and I have been doing for the last 5 years, and we're grateful to acknowledge the funding we've received from the National Institute on Aging through the NBER. So I thought I would talk a little bit about the themes of the book, that even before the arrival of COVID-19, the lives of Americans without a 4-year college degree, which is 2/3 of the population between 25 and 64, their lives have been coming apart. And in the book, we document what that means in terms of despair and excess mortality. And then we try to dig in and talk about the long run forces behind this and what might be done about this. Now, the work started when we noticed that for white non-Hispanics in the US, mortality rates, all-cause mortality rates, started rising in the late 1990s. Now, what you're looking at here are deaths per 100,000. So you can think of this as the risk of dying in any particular year for people aged 45 to 54. And if you look at comparison countries, the rich countries of Europe and the English-speaking countries, mortality rates in midlife were falling at 2% per year, as they had through the 20th century, more or less, continuously. For Hispanics, which is the thick blue line, their mortality rates were falling also at 2% a year. For African Americans, whose rates are higher than whites, whose rates continue to be higher than whites, their mortality was falling at 2.6% a year. So the odd man out here looked like, to us, were non-Hispanic whites, and we wanted to dig in and see what the causes were. One of the things that we understand now, which also wasn't getting a great deal of attention, was that heart disease mortality rates, we made great progress in the 20th century with inexpensive, effective antihypertensives, with getting people to stop smoking. Mortality rates, that was a great driver of a downward trend in mortality rates. Well, for white non-Hispanics, heart disease mortality rates flatlined, which meant they weren't going to contribute anymore to the progress. So it wasn't just that our progress against heart disease became anemic, but there were 3 causes of death where we saw death rates actually rising. And those were for drug overdose, for suicide, and for alcoholic liver disease. Now, what you're looking at here are mortality rates for one particular group. These are people aged 50 to 54, white non-Hispanic men and women 50 to 54. Drugs on the left, suicide in the middle, alcoholic liver disease on the right. And I've divided it here between people with less than a 4-year bachelor's degree and people with a BA or more. And while rates for drug overdose have risen a little bit for people with a BA, you see that there's this stark difference in outcomes where having a bachelor's degree is a dividing line. It turns out also that since the birth cohort of 1945, the fraction with a BA has changed very little. It's nosing up now some, but what you're looking at here isn't being driven by, say, selection into a particular group, like the group without a bachelor's degree. Since 1989, the standard US death certificates now record education. You can't reach back farther than that. And it took a few years for the states to come up to speed. But you can see that our look back at this can take us back to 1992. Now, this is for people aged 50 to 54. But what we find is that we find this in every 5-year age group. 25 to 29-year-olds on the upper left, 60 to 64-year-olds in the middle right. And we had originally hoped that maybe between having Medicare and Social Security, this wouldn't bleed over into the elderly. But if you look at what's happening to the 65 to 69-year-olds, it's beginning to happen there as well. And what's happening is that birth cohorts that have been touched by this are moving into older age, and they're taking their dysfunctions with them. In 2018, there were 158,000 deaths in the US from drugs, alcohol, and suicide. That's about the number we're at for COVID as I speak today. There were 65,000 deaths of despair back in 1995. So there's been this march up in these deaths, and it happened quietly, we think, because it was happening to people without a bachelor's degree. So it was happening below the radar. Now, these 3 causes of death are different, but we think they share a lot in common, that they're all death by one's own hand, and they're all a signal that someone's in quite a lot of despair. So we bin them together, although if you do this analysis, drugs by itself, alcohol, suicide by themselves, all 3 of them are showing the same signs. It took us back to Durkheim, back to 1897, when he wrote his famous tome on suicide and talked about the role of social integration. And suicide, he posited, is more likely in times of great upheaval. And we think we're in a time of great upheaval now. So what do we know about the people who are dying? One thing is that this is geographically widespread. Every state, now this is going to get nerdy here for a second, every state saw increases in deaths from suicide, deaths from drugs, deaths from alcohol between 2000 and 2018 for 25 to 64-year-old age-adjusted white non-Hispanics. So it's happening in every state. It's also happening to men and to women. So again, just to take one particular group, but I could show you this for other groups as well. If you look at deaths of despair for this group for age 50 to 54, what you see is that for men and women without a BA, there's been this marked increase in parallel over this period from 92 to basically the last years in which we have data, which currently is 2018. Now, men are more likely to kill themselves in any of these ways than are women, but the increase for men and women without a college degree has been almost identical. So headline writers like to say white men dying. And I think it's possibly because they didn't think that women could kill themselves in these ways. And if you go back far enough in the day, it did not happen to women, but that has changed. Oh, I wanted to remember to ask you, can you find the Great Recession in this picture? Because if you do, please let us know. We had thought originally that we would find concurrent economic conditions would predict this increase, these rises. And we tried very hard to find that unemployment or income or poverty, and did those correlate with these deaths. And we don't find that the concurrent conditions are what are driving this. We think that the roots of this are much older. And then underneath these mortality counts, we document in the book the fact that there's been this enormous increase in America in reported pain and reports of poor mental health, but only for people without a college degree. Now, because pain and mental health are self-reported, they're much easier to dismiss. But when you combine them with these increases in mortality, we think this fits into a larger picture and shows just that the mortality counts are just sort of the tip of the iceberg here. What do we think are the roots of this? Well, we think it's actually the long-term decline in the labor market for less skilled workers. We don't think necessarily that it's about just the material welfare of these people, but the fact that without a good job, a job with wages with which you can make a family life for yourself, the change in the labor market brought a loss of community, a loss of marriage, a loss of status for people doing lower skilled work. Also, concurrently, a loss of political representation in Washington. The unions used to be a countervailing force to the owners of capital. The unions basically cannot play that role currently, and labor doesn't have a voice. Just to show you what that looks like in black and white, if you look at men 25 to 54 without a college degree, and you look at their median wages, so the 50% mark in the left-hand panel, and you take that back to 1980, what you see is a long-term decline in the wages of people without a BA, of men without a BA. Now, there was a lot of celebration about the fact that at the end of this period, wages were rising before COVID came along. And yes, wages were rising, but you can see it's nowhere near where it was before the Great Recession, much less what it was like in the 1980s for people, for less skilled men. And on the right-hand panel, you can see that it's also meant less labor force attachment. If you take the employment to population ratio, what you find is that with every recession, which are the little red vertical lines you can see, employment to population would fall and then it would climb back up as people found new jobs or recalled to old jobs. Then it would fall again at the next recession. But the peaks never reached the peak that it was at the last time this happened. So there's also been this long-term decline in attachment to the labor force. And we think that labor force attachment brings a sense of self as well, and that the loss of jobs and the loss of good jobs has a lot to do with why we see mortality rates rising in these ways along the way. So there's a little change within a job. The loss of wages and lower labor force participation come about from losing, and then losing a job and perhaps returning to the labor force, perhaps not. A lot of the replaced jobs are worse jobs. They're outsourced jobs to transport or security or food services. There's less commitment by either the employer or the employee. The jobs have less meaning. It's harder to see them as being part of a good life. And in 1980, even lower skilled workers could see themselves as belonging to a larger company. As one colorful economist said, they would be invited to the holiday party, and that's no longer happening. So what happens when you don't have a good job, our friends in sociology have been telling us for a long time, is that you feel you can't get married. One of the partners has to have a job with prospects. People have been cohabiting in much larger numbers and having children in a cohabitation. But those cohabitations are quite fragile, unlike cohabitation in Europe. So what we see is serial cohabitation. It's possible that a father may not know his kids because they're living with some other guy now, and that there's no stability in home life, and there's no stability in work life. Community life has changed dramatically. There's less attachment to organized religion as well. And regardless of what you may think about organized religion, it's an institution that in the US has been extraordinarily important for 2 centuries. So people are left out there flying on their own. And that is really a Durkheimian recipe for suicide. In the book, we have a whole chapter where we look at the parallels between what happened to the white working class during this period and what happened to the Black working class in the late 1960s and through the 1970s as industry left the inner city. And at that point, marriage rates declined, out of wedlock childbearing went up. There was a crack epidemic. Well, those are parallels to what we're seeing now for the white working class. Obviously, the parallels aren't perfect. Obviously, with whites, we're talking about a group that's been more privileged than any other group. But for this particular group of low-skilled workers, they're seeing a loss of meaning in life that seems to be driving them to social dysfunction and to suicide. Now, what happened to the white working class? There's been a lot written on globalization and automation, removing the jobs that would have been good jobs for working class people. But that's true in other rich countries as well, who haven't seen their deaths of despair rise the way they're rising in the US. So we wanted to know, well, what's different about the US? Obviously, our safety net is different, and we discussed that in the book. But the 2 things I want to talk about today, one, which Alicia mentioned, is the opioid epidemic. So we argue in the book that the despair preceded the opioids. Deaths from drugs and alcohol and suicide were rising before the arrival of OxyContin, which is basically heroin in pill form with an FDA stamp on it. But the fact that these drugs were being handed out in jelly jam jars made the crisis much worse than it needed to have been. The opioids landed on ground that was fertile for abuse, and in fact, pharma targeted areas of the country where they thought people were in despair, and where if they brought these drugs, they would be well received. So is that a supply effect or a demand effect? If the pharma companies are targeting these regions because they think the demand there is going to be stronger. What else is different about the US? Well, the US healthcare industry, which is the most expensive in the world, but on many metrics, even before COVID, on many metrics, delivers the worst health in the rich world. Life expectancy in the US fell for 3 years running, which hadn't happened since the last great pandemic in 1918. And in the book, we argue that life expectancy fell not in spite of what we spend on healthcare, but because of what we spend on healthcare. And it's here that I want to connect some dots as we move into the next part of the talk. But just to give you a sense of how the US is different from these other countries, we have data from our World in Data. So this is life expectancy at birth on the y-axis and health expenditures per person on the x-axis between 1970 and 2015. This is for the UK, and you can see that both healthcare became more expensive over time and life expectancy rose. If you put Australia, it's in the same neighborhood, a little more expensive at the beginning of the period, higher life expectancy at the end of the period. Here's Canada. Same neighborhood, a little bit more expensive. France. Switzerland is the next most expensive country relative to the US. You can see that they do quite well in terms of life expectancy. It's also a fair amount more expensive than what you find in the other countries of Europe. And how do we compare? Well, here's the US in 1970 to 1982. That takes us to 1990. And this is what we looked like in 2015. So we're a lot more expensive. We're twice as expensive as the other countries, mostly in Europe. We're a lot more expensive even than the Swiss, who have a very expensive system. And it's not performing for us. So we spend 18% of GDP, $1.05 on healthcare. Switzerland spends 12%. Then the Swiss live 5 years longer than Americans live. So that difference in spending of 5.4%, that difference, if you thought of that as just excess spending, that's more than $1 trillion a year. That number gets bigger if instead of looking relative to the Swiss, we look relative to the Brits or the French or the Australians. That's more than $8,300 a household. That's half again as much as we spend on the military, and that's just the waste. That has to come from somewhere, and it comes out of wages, it comes out of profits, it comes out of taxes. So unfortunately, a lot of people think that their employer-provided health care insurance is a gift. They don't realize that that gift is being deducted in part or in whole from what would be their paycheck. So if you go back to your intro micro course, if I'm paying someone their value to me, I don't really care whether I pay it to them in wages or I pay their healthcare premium. This much is what they're worth to me. So as their healthcare premiums become more and more expensive, their wages go down. Many firms who face their share, which is on average 71% of a $21,000 a year premium for a family policy, they're going to outsource those jobs. Those outsourced jobs are not as good. So the premium don't vary by what workers earn. It's like a poll tax. It's per worker. So it's a little like raising the minimum wage, where there has been an enormous amount written, but there's been very little discussion about what this healthcare premium does to people at the low end of the labor market. So financing healthcare in this way is like taking a wrecking ball to the low-skilled labor market. And states are suffering as well in a big way. Because they have to pay their share of Medicaid, it leaves a lot less for schools, for the once great state university systems, who now have to charge enormous tuitions to cover expenses because they're not getting as much out of the state coffers. There's not as much for infrastructure. So this is a gift that keeps on giving as money is funneled up the distribution to device manufacturers, to big pharmas, to hospitals. Then, with all that, along came COVID. And I'm going to speak on this for just a couple of minutes. One is to show you that here's the picture I showed you earlier of the employment to population ratio. This is now for all men, not just men without a BA. And you can see that we've fallen off the end of the earth here in terms of the employment to population ratio after COVID hit. The unemployment rate for people with a high school degree, no college, in May 2020 was 15%. And the employment population ratio for people 25 and over with a high school degree has fallen to less than 50%. This is more trouble coming down the line. Social distancing is going to widen the gaps between the haves and the have-nots, with people with a BA and people without a BA. Because without a BA, you're either an essential worker, in which case you put your health at risk, which is going to make the health inequalities greater, or you're an essential worker. No, you're a non-essential worker and you don't get paid. So the likes of me, I get to stay home. I get to work from home and I get paid. Thank you very much. But a lot of people are not in that position. So the earnings inequalities are going to rise as well. African Americans were exempt from deaths of despair until the arrival of fentanyl as a street drug in 2013. Before then, deaths from alcohol and drugs were falling in the Black community. Suicide rates have always been and remain fairly low in the Black community. But African Americans are obviously not exempt from COVID. And Hispanics, who have better health and longer longevity than whites do in the US, also are in the healthcare sector or doing essential work. So people of color are finding themselves at much higher risk from COVID than the likes of me. Some more educated people are certainly on the front lines, especially in healthcare. But this is something that has been really going to make people with less skills, without a BA, they're the ones who are going to be struggling going forward for as far into the future as we can see. Now, the question has been raised to us, will COVID exaggerate these deaths of despair? And I'm here to say it is way too early for us to know. We won't know this about suicide or alcoholic liver disease for a very long time. There is a rapid release of data on drug overdoses. Drug overdoses, which took a little vacation in 2018, started to rise at the beginning of 2019 and have been rising since. So they've been rising through the COVID epidemic. Now, there's a group who very kindly and very well map the detection of overdose throughout the country. And they have a program called ODMAP. And they released a new paper in their ODMAP report of June 2020, in which they argue that drug overdoses are rising in response to the lockdown. Now, what you're looking at here are not deaths, but drug overdoses. So some are fatal, some are not fatal, in each week of 2020. And I've circled the 10th week of March, which is when the national lockdown started. And it is true that if your eye looks to the right, the data there show more overdoses than when your eye looks to the left of the 10th week. But the truth of it is, they've been rising since 2019. So there's no break in the series with the 10th week of 2020. A lot of stories are getting written, and there is a lot of heartbreak that people died of drug overdoses who would probably still be with us if they could have gotten their shot, if they could have gotten Narcan, if they didn't have to turn to more dangerous street dealers because their dealers have disappeared. So yes, definitely there is a lot of heartbreak here, but it's hard to pin this on the lockdown. This is part of this longer term epidemic that's going to be with us well after hopefully the vaccine or the treatments come for COVID-19. We have no reason to believe that suicide, drug overdose, or alcohol liver disease mortality is going to fall just magically. We're going to have to do things to shore up the lower end of the earnings distribution, people with a lower skill set, people without a BA. So what do we want to do here? We called it the future of capitalism, not the failure of capitalism in the title, because we just feel like capitalism is a good thing. Capitalism has brought billions of people around the world out of dire poverty. It needs to be fixed again in the US. It needs to be made fair. It does not need to be abandoned, is our take on this. Now, what can we do now? One of the things that's going to happen is there has to be healthcare reform. This is an injury we're inflicting on ourselves, and the people who are really bearing the burden of that are people with lower skills. Now, the COVID crisis may give us an opportunity to do that. It could be in the end of the day, there's a vaccine and suddenly Big Pharma is the big hero. I mean, partially this is going to depend on what the vaccines are, what they charge for vaccines when they become available, or treatments when they become available. But millions of people presented at hospitals, millions of people have probably been exposed to surprise medical billing, coming in through emergency departments that have been bought up by private equity that are not taking in the insurance that the hospital that the ED is attached to takes. And these people will be presented with bills they cannot pay. When this happens to enough people, there may be enough force to push some change. It's going to happen in the middle of the distribution. It cannot be just people on the far left arguing that we need change in the system. It's going to have to be a conversation we have with people in the middle of the distribution. And with COVID, that might happen. I think what happens generally is that people know healthcare is extremely expensive. They also know it's really complicated, and they kind of shrug and they move on to whatever else they're worrying about. Their attention needs to be drawn to this. Now, they're up against a very powerful force here. There are 5 healthcare lobbyists for every member of Congress. And the newspapers are currently documenting the ways in which those lobbyists are getting some of the relief bills funneled toward their firms. But in a crisis, sometimes the lobbyists have less power and real change is possible. More generally, there's been a rise of corporate lobbying and a decline of unions that would represent less educated workers in America. And we know the old expression, if you're not at the table, you're on the menu. So we have to find some way that we're going to reweave the social contract here between people, between labor, and between the owners of capital. Part of that is going to have to be through changes in education. People with coming out of high school are coming out of a high school that was really there to train up kids who were going to college. Among the people not going to college, the skill sets they've been left with do not offer them the chance to participate in a way that's going to allow them to get good jobs. So there are a number of steps that we need to take going forward. And we know that COVID right now is front and center, but I just want to leave you with the thought that this problem is not going away, and we're going to have this conversation too. So that's what I have, and I'll stop there, and I'm very happy to take questions or discuss anything.
Thank you so much, Anne. It was as wonderful a talk as I had expected it to be. And I do have a bunch of questions from the audience. From Michael Hurd, his question is, do you see a role of inequality, envy, in driving these effects? If everyone's income were falling, would the effect be different?
Inequality is such a hard topic because I don't think of inequality as being one thing. I think there are different ways that you get to inequality. I think that if someone invents something and we all benefit from it, we don't feel envy if that person becomes rich. We celebrate that person. But in a system where there's a lot of rent seeking, when there are a lot of lobbyists making special rules and people begin to think that the system is rigged against them, then the inequality leads to real resentment. So I think of deaths of despair and inequality as both being outcomes of this fundamental procedural unfairness that is dictating what's going on here right now.
That makes sense. I have a second question from Anne Brookhart. Her question is, how does the increase in deaths of despair compare to increases in other forms of death among those with less than a college degree? You mentioned health, not hearts, but if you could expand.
Sure. There's actually a figure in the book that shows that for people in midlife, starting somewhere in the 2000s, and I don't have this date in my head, deaths of despair became a larger cause of death than heart disease, and a larger cause of death than cancer in particular age groups. So it is not, it's really a non-trivial cause of death among people without a BA. And of course, for younger people who generally don't die of anything, it's a very, very high fraction of younger adults who are dying. We used to think that alcohol, we being me, that's me, we used to think that you had to wait until someone was like 45 before you saw deaths from alcoholic liver disease, because the liver is such a robust organ and it can take a real pounding. But what we're seeing now is death rates from alcoholic liver disease rising for people in their late 20s and early 30s, because it's binge drinking that's really toxic to the liver. And there's a lot more binge drinking than there was. So even as we go down the age distribution to younger people who don't die of heart disease or cancer as much, this is huge. But even in midlife, it's become a larger source of death than, say, heart disease.
So can I just ask one of my own questions? Because, this is the consortium of retirement and disability centers, and I'm not a disability expert, but disability roles have been going down. And you've had this whole trend towards deaths of despair has involved a deterioration in health generally. And so I'm surprised that that hasn't had more of an impact on the disability roles. Any idea why that hasn't happened?
No, I thought you were going somewhere else with that, which is what we see, which I didn't get a chance to talk about today because it's more complicated to explain. What we see is birth cohort to birth cohort, later born birth cohorts report more pain at any given age. So I would have expected as well that the pain increases would have been concurrent with increases in disability roles. So what we're seeing, go ahead. No, please, please.
No, so we'll have to go with disability experts for that. But one of the questions from the audience did pertain to this issue of pain. And he was wondering whether you thought that the push towards pain as a fifth vital sign in the 1990s has anything to do with the rise in pain reporting and in the increase in opioid addiction.
That's a really good question. And because pain is self-reported, we have no way of knowing if basically at the same level of pain, people are more likely to report pain than they've been in the past. That's a real possibility. But that alone doesn't explain necessarily this at any given age that later born birth cohorts report more pain. From the National Health Interview Surveys, those people who are reporting pain are also the people who report they have trouble with activities of daily living and adults. They report more social isolation. They have difficulty socializing with friends. They have difficulty walking. They have difficulty sitting for a period of time. So it is a self-report. So are these other things, yes, but they go together, and it makes us think it's possible that those are real. But I want to go back because I agree that there was a real push, and Big Pharma was very happy to play a role in that, in making sure every doctor's office had, how is your pain level today, and that you got asked your pain level, because that was going to be good for business. And what was good for business was really bad for the rest of us.
Very bad. And then I have a question from Steve Goss, who's the Chief Actuary of Social Security. And he says, do you think that attention to the national infrastructure would help reverse these trends? And I think he must mean the sort of increase in good paying jobs.
Well, I think that we certainly need to find a way to find good jobs for people with skills that don't include a BA. Absolutely. And I think that if we could, that's got to be on the agenda. And it's going to be one of the sort of really great byproducts of moving to a system in which we provide the kind of education that allows people to take good jobs that require skills, but they may be different skills than the skills people might get from going to college.
And so I guess my last question is that you found this trend, you identified this trend in around 2015, but it had been going on for quite a period of time. And I feel like all of us professionals should have seen it earlier, and maybe we could have done something about it. Does that make any sense to you?
It makes sense, but it was small at first, right? It's something that just was growing over time, and I think it had to get to be big enough to do something like cause mortality rates be one of the things that caused all-cause mortality rates to rise before the bells started to ring. It is true that the CDC, which is underfunded, had people who were writing reports saying that suicides were rising for white non-Hispanics. In a very different part of the CDC, people were writing reports on the fact that alcoholic liver disease was going up for white non-Hispanics. And of course, NIDA was doing the drug end of that as well. But those reports were, except for the drug ones, were not getting any attention. They weren't getting any traction. But when you put them all together, you see the problems much bigger. So I think that if we have underfunded CDC for a very long time, and I think that they do very good work, and we should support them, because I think that would have been a place where all those things could have been brought together.
Yeah, I couldn't agree with you more. So our time is almost out. I just want to thank you again for taking the time to do this. It's one of the most important, interesting things that people are doing in the economics profession. And so we are so delighted that you could be able to join us today.
Thank you so much, Lisa, for the opportunity. I really appreciate it, and I feel honored to have been asked. So thank you very much.
Take care.
Stay safe, everybody.